May I please call Dr. Talvir Sidhu? She's going to talk to us on diagnostic gonioscopy.
A very good morning. I'm going to talk on diagnostic gonioscopy. So at the start, I would like to thank my teachers, Professor Ramanjeet Sehota and Professor Tanuj Dada. The first thing that we need to know is what kind of gonioscopes are we using? Is it a gonioscope which can be used for manipulation gonioscopy, or is it a gonioscope that can be used for indentation gonioscopy? Manipulation gonioscopy, it uses a 2-mirror Goldman type gonioscope, while the indentation gonioscopy uses a 4-mirror gonioscope, a Zeiss type gonioscope, where the well is smaller and it can be fit over the cornea without using a coupling fluid. Also, while performing gonioscopy, it is important that it is done in a dimly lit room, because if you increase the light in the room, the pupil will constrict and artificially open up the angles. Also, it is important to make yourself comfortable and use a hand rest. Instruct the patient to look straight while you are applying gonioscope over the eye. So while applying a gonioscope, the patient can be asked to look upwards. You can use a swab stick to retract the eyelid and put a gonioscope over the eye. It is important that the edges of the gonioscope is not chipped, because they can cause corneal or conjunctival abrasions. When you start the gonioscopy, it is important that you use a 2 millimeter small thin slit beam which does not touch the pupil, because if it touches the pupil constricts and artificial opening of angle can happen in people who have angle closure. It is also not a rule, but generally the superior angle is looked at first because it is the narrowest angle in the eye. If you press on the gonioscope too much in a Zeiss type gonioscope, it will cause corneal folds, as can be seen in the picture, and it will lead to artificial opening of the angle because it pushes the aqueous into the angle. Also, when you do gonioscopy, it is important to form a pattern, and it is also important to follow a pattern. So the first thing to note is what is the posterior most structure visible. Is it the shawl base line, the trabecular meshwork, the scleral spur, the ciliary body band? So these are the structures that are usually visible in the angle. You ask the patient to look straight and see which area is visible. In an open angle, usually the scleral spur, here you can see an open angle, you are able to see the scleral spur, the trabecular meshwork and the shawl base line. Here also this is an open angle where you can see the ciliary body band, and the other angle structures are lightly visible. This is a closed angle where you cannot see any angle structures, and here you can see that there is some pigmentation in the angle, but is it the trabecular meshwork or is it some pigmentation that is present over the shawl base line? To decide that, we can use a corneal wedge technique. A corneal wedge is formed by the reflection of light on the inner surface and the outer surface of the cornea in the form of a U at the level of the shawl base line. So if any pigmentation is present at the level of the corneal wedge, it is actually present at the shawl base line. In an open angle, you will be able to see a corneal wedge, and following after that there is a straight line that is present. But in a closed angle where there is some pigmentation over the shawl base line, you can see that the pigmentation is actually forming at the level of the corneal wedge, and the other angle structures are actually hidden behind the iris. So this is a corneal wedge technique which can be used. So here you can see corneal wedge formation in an open angle and a straight line behind it. You can see a corneal wedge formation in a closed angle. There is no straight line behind it. You can see that the iris is pretty much hiding all the angle structures behind itself. The second thing to note is an angle recess. Angle recess can give you slight quantification, a subjective quantification of how much angle is visible. So this is the angle between the line on the cornea and the light line on the iris. So you can see that this is almost 40 degree in an open angle, but in a closed angle you can see that the iris is bowing upwards. That is why the angle between these two lines has decreased, usually less than 20 to 15 degrees. Iris configuration is also important. In open angles, you will see that the iris is usually lying flat over the lens. In closed angles, the iris is convex, it is bowing upwards. In some patients where there is concave iris configuration, the iris might be rubbing the zonules, leading to pigmentation release in pigment dispersion syndrome. After that, it is important to note what is the angle structure that is seen after manipulation. So in this video, you can see that the patient is asked to look towards the mirror, and when the angle opens up, the entire scleral spur is visible. Whereas in this angle, you can see some blotchy pigment is present inside the angle. And this blotchy pigment can later on lead to formation of goniosynechiae, where the iris sticks to the trabecular meshwork, leading to presence of goniosynechiae. Similarly, you will be able to see multiple goniosynechiae in people who have ongoing angle closure. Indentation gonioscopy can also be done, where you can press on the cornea and actually leads to opening up of the angle. So here you are pressing on the cornea and you can see the entire scleral spur becomes visible. So this is a indentation gonioscopy. Sometimes zipper angle closure might also be present in patients who have ongoing angle closure. Level of iris insertion may be different in people who have the iris lying flat, and the level of level of the iris insertion must be noted. Normal iris insertion is usually over the ciliary body or behind the scleral spur. In people who have juvenile open angle glaucomas, you might be able to see anterior insertion of iris, like over the trabecular meshwork or over the shawl base line. So this is a juvenile open angle glaucoma where the angle insertion is on the shawl base, on the scleral spur. In congenital glaucoma, over the shawl base line. Similarly in aniridia. Other abnormalities like increased pigmentation may be present in pigment dispersion syndrome. In pigment dispersion syndrome, a band-like pigmentation, fine pigment is present in the angle with posterior bowing of the iris. In pseudo exfoliation, you will be able to see some whitish material and salt pepper-like pigmentation in the angle. Iris processes are also important to note. They are present in normal angles or sometimes increased in juvenile open angle glaucomas. They must be differentiated from goniosynechiae. Goniosynechiae usually do not follow the angle contour, while iris processes are finger-like and they follow the angle contour. Blotchy pigments and goniosynechiae are present in angle closure glaucoma. They warrant doing a YAG iridotomy. Uveitic glaucoma and Axenfeld-Rieger syndrome may also have goniosynechiae, but YAG iridotomy may not be needed in these cases. It's also important to differentiate normal angle vessels from abnormal angle vessels. Normal angle vessels are usually over the iris, whereas abnormal angle vessels are usually crossing the scleral spur and the trabecular meshwork. So here I would like to end with another finding which is seen usually in traumatic glaucoma, that is abnormal angle recession. Abnormal angle recession is widening of the ciliary body band, which can be seen in traumatic angle glaucomas. So it's important that when you have a patient who has an increased IOP, it is important to do gonioscopy in all these cases, because it will help you form a diagnosis. It might change your diagnosis. So always do gonioscopy. Thank you.
Thank you, Talvir.